Welcome to your channel Clinical Consultant. This time we will talk about the last topic in the anemia series called Sideroblastic Anemia. Without more to say, let's continue with the video. Definition: Sideroblastic anemias are blood disorders derived from an alteration in heme synthesis and are classified as hereditary, acquired and reversible. Epidemiology and demography. Hereditary sideroblastic anemia is related to sex and affects mainly men. Primary acquired sideroblastic anemia is a disorder in the elderly. Signs and symptoms. The symptoms of sideroblastic anemia correspond to those of any anemia. Symptoms include fatigue, weakness, palpitations, dyspnea, headache, irritability, and chest pain. Physical findings include paleness, tachycardia, hepatosplenomegaly, S3, TVY, and rales. Etiology. The exact cause of many cases of acquired or inherited primary sideroblastic anemia is unknown. However, in some cases, the underlying molecular defect affects the genes that they encode. The enzyme 5-aminolevulonate synthase, mitochondrial iron transporter, ferrochelatase, cytochromoxytase, mitochondrial proteins as in Pearson marrow-pancreas syndrome, hereditary primary sideroblastic anemia, can be inherited as a recessive sex-linked disease. Secondary acquired sideroblastic anemia may be due to alcohol, isoniazid, pyrazonamide, cycloserine, chloramphenicol, and copper deficiency. Differential diagnosis. Sideroblastic anemia must be distinguished from other causes of microcytic hypochromic anemia, such as iron deficiency anemia, thalassemia, anemia due to chronic diseases, lead poisoning and blood loss. Tissue iron overload and sideroblastic anemia behaves the same as hereditary hemochromatosis with liver cirrhosis, diabetes, congestive heart failure and cardiac arrhythmias. Medical evaluation. The diagnostic evaluation of a possible microblastic anemia includes laboratory studies and also bone marrow aspirate and biopsy. Lab tests. Sideroblastic anemias are characterized by hypochromic anemia, low hemoglobin, high MCV, and high red blood distribution width. The determination of iron, Tib, ferrite, free erythrocyte protoporphyrin, copper and zinc, can all help us to diagnose sideroblastic anemia. In the peripheral blood process we find dimorphic large and small cells, showing Pappenheimer bodies or siderocytes, when taken for iron. The bone marrow shows the classic ring sideroblasts, absent in normal bone marrow. Ring sideroblasts represent iron deposits in the mitochondria of normoblasts. In this image we can see the iron deposits on the left side. We can see a peripheral blood smear where we see iron deposits in the erythrocyte membrane. In the image on the right we can see the common to see ring sideroblasts and normoblasts. If you wonder what normoblasts are, they are the predecessors of erythrocytes. If you like our content, give it a like and subscribe to the channel. Let's grow together, my dear. Non-pharmacological treatment. Avoid alcohol. Sideroblastic anemia secondary to isoniazid, pyrazonamide, and cycloserine should completely improve when medication is withdrawn and vitamin B6 administered at 50 to 200 mg daily. Acute treatment. In hereditary sideroblastic anemia, almost 35% of patients receive vitamin B6 at 50 to 200 mg per day. Improves their HemSD count to near normal numbers. The rest of the cases need transfusions which treat the symptoms of anemia. In primary acquired sideroblastic anemia, most patients do not respond to vitamin B6. Some success with the administration of erythropoietin has been shown to improve anemia. Blood transfusions are indicated in patients with symptomatic anemia. Chronic treatment. Hereditary sideroblastic anemia. Organ dysfunction secondary to iron overload requires periodic phlebotomies. In advanced cases, 40 mg per kg per day of intravenous defruxamine are administered. In primary acquired sideroblastic anemia, as in the hereditary form, periodic phlebotomies are indicated. when serum iron concentrations are greater than 500 micrograms per liter and defroxamine in patients requiring frequent blood transfusions. Forecast: hereditary sideroblastic anemia. With the treatments discussed above, the prognosis is good and life expectancy is normal. And primary acquired sideroblastic anemia. Patients who only have anemia, life expectancy is normal. But patients who depend on blood transfusions may have morbidity from dysfunction of some organs. Some patients with acquired sideroblastic anemia can develop leukemia. Comments: Sideroblastic anemia can be considered an iron overload anemia secondary to defective heme synthesis. The protein enzymes necessary for the synthesis of heme are found in the mitochondria of erythroid cells. A reduction in the activity of this enzyme, be it deaminolevulinic acid synthase or ferrochelatase, alters the formation of protoporphyrin and the incorporation of iron to it, prevents the synthesis of heme. Iron continues to be absorbed in the digestive system, and mitochondria surrounding the normoblast nucleus accumulate, giving rise to the annular sideroblast. Vitamin B6 pyridoxal phosphate is a necessary cofactor for heme synthesis, and some drugs such as isoniazid cycloser and pyrazinamide can inhibit its function. Thank you very much for watching the video. Give it a like, subscribe and comment on the next video. It will be babesiosis.